Medicine podcast with me, Dr. Amie Burbridge. Today I'm joined by the ever wonderful
Dr. Stephen Montgomery Laird.
Fantastic, thank you so much for joining me. Today we are going to talk about influenza. We are heading into the autumn and winter months and we are going to be seeing more cases of influenza. So I thought it would be a good idea to have a bit of a recap. So Stephen, you are a microbiologist and an infectious diseases consultant. So this is the bread and butter of your work.
It is. I mean, a lot of trusts will have specialist virologists, and the place in that we work, Amie, we're lucky to have a virology team which cover our network, with deal with the majority of this. So first and foremost, I think I've got to say thank you to all of those guys for really help supporting from the clinical aspect for things like flu and COVID. They do a lot of the work. They do a lot of the work in the lab, and they do a lot of the setup work that is required when we go into these different seasons, which you're right, has been different over the last couple of years. And I think we have forgotten about flu a little bit, but we do have, majority of trusts will have some form of at-the-door testing for a number of different respiratory viruses, dominantly flu A, flu B, and RSV in the PCR machines that they might see at the front door. I won't use trade names, but we have a very good system. And then, of course, there is that PCR test, that quick PCR test that we can do for COVID. And I think a lot of people, like you said, because of the pandemic, have just been sending samples purely for COVID. That did change about a year ago, maybe a little bit longer, when we really had a push to see what was going on in our population, especially for those COVID negative people, because influenza is still a huge killer worldwide.
Yeah, and I think that's what we often forget, is actually before COVID, we had a really aggressive viral illness of influenza that actually killed large numbers of people every year. And hopefully by the end of this talk, people will be much more aware of influenza and remember it when they see patients over the coming months. Yeah. So going back to influenza then, how would a typical patient with influenza present? What sort of things can we expect to see?
So a typical patient, so first and foremost, the worrying cohort of population that we think about that may present a little bit more severe or a little bit more atypically would be that the child below 5 years old, the immunosuppressed population, and that can be any form of immunosuppression. The population above 65 years old, of which is our bread and butter work in the NHS commonly. And then, of course, people with chronic disease as well, significant chronic disease. They might present a little bit different, or they might present a little bit more severe. But the common things that we will see in our population generally will be that sore throat, that upper respiratory tract infection signs, the rhinitis, the cough that comes with it. And then you have that myalgia. And of course, the dominant thing that we see with all influenzas is the fever, but especially at the very early stages. And remember, having a fever is 38 and above. It will be different for different people. People might run at 35.3 usually and have a fever at 37.6. But for definition sake, we're saying a fever is above a temperature in Celsius, because there might be people listening in different countries who measure in Fahrenheit, of 38 degrees Celsius. Yeah.
Okay, so it's that fever that is a predominant feature. And that happens quite early on, doesn't it, in the influenza course, within a couple of days?
Yeah, so if you have contact with somebody with flu, then the incubation period is roughly 1 to 4 days. And on average, it's within 2 days, you will have some form of symptom. And fever comes, the headache comes, of course, headache, I didn't mention headache, the rhinitis comes, and then you might feel just a couple of days later really tired. That malaise kicks in, that myalgia kicks in. And if people have been traveling all over the world, this doesn't help, because it can be anything. It literally, and that's why it's such a difficult diagnosis to make sometimes.
Yeah, absolutely. So I had the flu when I was 16 and I never forget it. It's even now, it stays in my head, just that overwhelming, complete and utter exhaustion and inability to get out of bed. And I remember my mum put me in the car and drove me to the doctors because she was convinced I had meningitis because of that headache, that widespread body aches and pains, that sort of neck stiffness. And I remember the GP saying to my mom, this is a meningitis, she's got the flu, take home, put to bed. And I was like, how did they know that it wasn't meningitis, you know? And I think that's something that at the front door, that's certainly something that we need to be very good at, is actually trying to identify which could be something more serious in the young, like a meningitis. Not that influenza isn't serious, but something like a meningitis that would need antibiotics versus an influenza that wouldn't need antibiotics.
Absolutely. And actually the differential, I mean, it would include that you'd need those extra symptoms, I guess. That photophobia usually helps. You don't usually get that in a simple influenza. You can get, of course, the complexities of having an encephalitis with influenza, but you wouldn't have the photophobic meningitic symptoms that they have. That would be more the confusion with the fever and the drowsiness leading into something really, really significant, of which any front door physician will be admitting that patient.
Mm-hmm. So if you were admitting somebody over the age of 65 or an individual with frailty, so they have that sarcopenia, that generalized fatigue, they're over the age of 65 and they may have multiple comorbidities, how might these individuals present differently to somebody in their 20s or 30s with no past medical history of note?
It just might be the severity. It's still going to have the same symptoms. It's not as though we're going to say that the rarest symptoms are going to present more in these patients, like cervical lymphadenopathy, which is much, much rarer. We're not going to say that we're going to well, they're probably usually much, much sicker, and that's why they would need admission. Or you're worried that their trajectory is not as you would expect. It's not holding in a kind of an upper respiratory tract dominant infection with myalgia and fever. It's going into the chest. It's causing a significant pneumonitis, dyspneic, and they require some form of secondary care support.
So what about those individuals? Are they more prone to developing a secondary bacterial pneumonia as well?
It all depends again on what type of immunosuppression that they will have. If somebody was 96, they're going to do worse from flu. They're going to do worse from generally a lot of things, because there is going to be an associated frailty that comes with age, and you just want to keep an eye on them. So those signs are going to be there. You're going to maybe have, after a couple of days, a neutrophilia, which you don't usually see in flu, and you don't usually see that really big CRP rise that we saw in COVID. That was quite an unusual differentiator, wasn't it? We saw a huge amount of inflammation that was coming because of COVID. In influenza, we don't see that as much. We think of this as the standard kind of blood work that you would expect to see with a respiratory viral illness. And that has become systemic. So if they're coughing up green sputum, whoa, hold on, that's not, this should be a dryish cough that's just really irritating and causing problems. So we're starting to think this person is starting to get a Staph aureus or a strep pneumo, secondary bacterial infection. On occasion, we have seen as well in the immunosuppressed, they might be more prone to getting a fungal infection as well in the chest. They might have an aspergillus infection, but you know, we would just have more caution with these patients. And if we have the facilities in our area to put them into a virtual clinic, then that might be the way forward, of where we can send them home, refer them into a virtual clinic for follow-up and for pulse oximetry testing. Or we may just send them home and give them a ring in a couple of weeks' time. Or if you're really concerned, you bring them in.
Yeah, absolutely. I mean, I've just remembered another high-risk group as well, which you can't forget, is pregnant women.
Oh my goodness, yeah, I'm so sorry that I didn't actually say that at the beginning, and I would bring a pregnant woman in.
Yes, and it's just came to mind just because I've recently been pregnant, and I actually had COVID and was really poorly, and probably more poorly than I would have been if I hadn't have been pregnant. And I think it's an extremely vulnerable time for the mum and the baby. And certainly in the UK, all pregnant women do have to have, well, they don't have to, they're encouraged to have the influenza vaccine. That is another high-risk group I've just thought about. Okay, so you've got somebody who's presenting them with the symptoms that you do think is influenza. I mean, certainly from an acute physician perspective, actually a lot of patients I probably wouldn't admit to hospital if they had influenza, unless they were in that high-risk group or they had a superimposed bacterial infection, or it was a slightly unusual presentation that I wasn't quite sure about. So Are there any must-do investigations for patients who you think have influenza?
Well, serology tests are useless. So we please just don't even try and think about asking for serology tests. But the molecular tests are very, very good and very, very useful. So if you do have that facility where you can do a PCR front door and you can get your flu A, flu B and RSV check done, then that's very, very helpful. The rest of it, of course, you would want to think, if you've got a young population, you might start thinking about your differentials as well. People can present in different ways. We constantly talk about HIV seroconversion, and this would mimic this in your sexually active population. Take away age, because we never think, HIV can go in anybody who's having sex. And then things like, when serology comes in very useful, is things like EBV seroconversion as well. So that brings us on to that kind of population that we're dominantly going to see those big clusters and outbreaks in, which is usually at this time of year, the freshers, going back to the schools, getting lots and lots of respiratory viruses, mingling in with each other again at university, big freshers fairs, lots of close contact for whatever reason, and then getting potentially glandular fever, of which of course you would have those dominant lymphadenopathy and potentially a little bit of splenic pain. But outside of that, you do your full blood count, you do your U's&E's, and you would definitely do your basic observations to make sure that someone is not significantly hypoxic, even though they look really well at the front door. Would you do an ABG? No, you're not going to do an ABG on every single patient that's going to come through to make sure that they're absolutely not. Your pulse oximeter should be good enough to be able to quantify what's going on. Would you, though, Amie, I'm going to throw this one back at you because it's a question that I constantly think of. If you had a woman of childbearing age and you thought that they might have flu, would you do a pregnancy test to make sure that that wasn't an unknown pregnancy with influenza?
Absolutely, because I'm of the school of thought that every woman is pregnant until proven otherwise, because every woman of childbearing age who can be pregnant, if we are going to then diagnose or do further investigations, it's really important to find out if they're pregnant. I've had so many occasions at work where I've asked an individual if they could be pregnant and they've said no, and they've turned out to be pregnant. So I do think that's really, really important. It's one of my stock sayings, I think, that I tell all my trainees: every woman's pregnant until proven otherwise. So yes, I would do a pregnancy test.
And I guess it's especially important when you're risk stratifying, because that's not just a pregnancy test and a confirmation of a diagnosis. That's actually now a risk stratification on prognosis potentially.
Yeah, absolutely. So if we do have that diagnosis of influenza, I remember way back when I was about 2009, when we did have a bit of a flu outbreak and we were prescribing everybody antivirals who'd had a contact with influenza. Do you remember that? Or we used...
2009. 2009 was the big H1N1 pandemic. Yeah. Yep. So this is when we were starting to really appreciate what PPE was all about, what isolation was about, what cohort and patients was all about. Our A&Es were full of plastic sheeting, making isolation cubicles. This is when we really started learning as a world. And so we were giving everybody Tamiflu and not sure what the benefit actually was, and then giving everyone prophylaxis Tamiflu as well, oseltamivir. And we still do that to a certain extent. We will still offer people either post-exposure prophylaxis or treatment version of oseltamivir, or give some of the children over 5 zanamivir.
Does it work though?
So I think it's a controversial area of science, and I think what the thought process is that in a working person, they will be able to claw back 1.5 days worth of work with symptom reduction if given within the first 48 hours of symptom onset. So it will lessen their potential. However, we do give it to those high risk groups.
Okay. Yeah. And I think the key thing as well with the flu is, aside from actually treating the viral infection itself, it's about really telling individuals how to manage the symptoms of it, isn't it? So it's the regular paracetamol, regular anti-inflammatories if people find that works for them, and lots of fluid, if they can actually keep the fluids down. You don't want to be dehydrated. Food, I know, was challenging sometimes because you just don't feel like eating. So it's really ensuring you're getting that oral intake. And also, I guess it's about, do they have a secondary bacterial infection that's going to need antibiotics?
Yeah, absolutely. And we have to be very careful with offering people just the Tamiflu as well, because they're, like you said, eat it, you go off your food, but what you don't want to do when you're 70, 80-year-old is go off your food and then feel nauseous because of a drug that is being given for a prophylaxis that you're not quite sure if that's actually working or not for that person.
And that's a very good point, is that often what we do is we treat numbers, we treat diagnoses, we don't treat the individual. And you're absolutely right, you know, it's about thinking a little bit laterally, actually, that actually if I'm going to give this medication, they're going to feel even more sick, they're going to reduce their oral intake anymore, and actually in the long term it's really bad.
Yeah, and if we've missed that window period where we're not going to stop from developing symptoms, then yeah, we have to really think about what's best for our individualized patient. Mm-hmm. It's always difficult when it's a communicable disease, though, because obviously one patient then presenting in a very, you know, we've got restricted amount of side rooms in all of our different trusts, however they're set up, and cohorting somebody in a bay can be slightly, you know, you have to balance the risk. So it can be tricky, and I understand why people struggle with this year in, year out. You should be able to get your guidance from your virology team, from your infection control and prevention team. You will have your individualized guidelines, which will dominantly come from public health guidelines from UK HSA. But then you do have to think about what's best for your individualized patient as well, and make sure that there isn't a chain of consequence for that decision that you're going to make. So it's about reducing the risk and treating those patient cohorts appropriately. Yeah,
and I really like that phrase, a chain of consequence. I think I'm going to steal that. You know, I think you're absolutely right. You know, we treat an individual, but what is the consequence of that of everything else? Not just the individual, the other patients maybe in the ward, their families. It's massive, isn't it? So one decision can have a massive, massive impact. Absolutely. So I'm going to take us maybe a little step back now to talk about vaccination and the impact that vaccination has on the severity of influenza in an individual. And there's, you know, would you advocate that we should all get the influenza vaccine?
I do. I think everyone should get the influenza vaccine if they can. What's the word I'm looking for? If they, well, actually, you know, 2 years ago they offered it up to everyone, and now we all should, as healthcare professionals, definitely be vaccinated, because actually we want to be healthy within ourselves, but actually we don't want to be asymptomatic carriers passing it on to our patients, or coming in with that little cough and having a reduced kind of influenza and passing it on to our vulnerable patients who are going to do badly with it. So yeah, I think everyone, if a vaccine is offered, it's offered for a reason. These are not cheap things for the government to do, and a lot of thought process goes into that vaccination. So we always look at how the South Hemisphere has behaved with regards to their winter. This year we expect a very bad influenza season, hence why we're probably doing this podcast. We saw a massive rise in Australia, much earlier than what we would usually expect in their May and their winter. And it peaked, it soared, it went logarithmic compared to the average, which would be a little bit flatter than what it was. And that's for many, many reasons. The whole taking off your masks, people coming back together, and of course, people not being exposed to flu for quite some time, so they don't have that slight lingering immunity that they might have. And they might not be thinking about vaccination uptake as well, because they've just been prodded 3 times with COVID vaccination. A lot of people will start to think, how much is this wearing out my body, and all of that social media that's around taking too much vaccines, which in my personal opinion is ridiculous. Your immune system will cope with the vaccine. It's the whole point of giving a vaccine. Obviously, there are some consequences of certain vaccine, where there is healthcare professionals to guide people through it. And if you are offered a vaccine, take a vaccine, whether it be your measles, mumps and rubella, or it's your seasonal influenza jab to protect you and those people around you love or you're caring for.
And that's one key word you said there as well, was seasonal. You know, you have to have the flu vaccination yearly. It's, you know, you don't have it and then you're not then protected for ever, because I remember having this conversation with my grandma a couple of years ago, who didn't still quite understand that her one flu jab however many years ago, and she hadn't had it since. So it's a challenging conversation, but it's trying to get people to understand actually that you have to have that seasonal flu vaccination, because each year the vaccination that the flu is against is slightly different. So it's really important, isn't it, to have that up-to-date vaccination?
It does.
Okay.
And those antibodies wane as well. You've got roughly really good coverage for around about 6 months. But like you said, we've talked about H1N1, our dominant strain that we're seeing, and probably have for the last couple of years has been H3N3. These are different components of the virus particles. So it's about so we know that we can only make so much vaccine with so many of these virus particles in there to produce an immune response. We can't put all of them in because it would just be not cost effective, and we don't actually know how that would actually work.
Okay, fantastic. So everybody really should go out and have that vaccination. It's really important, not just for individual protection, but as you said, to protect those around you, those in other healthcare settings and general population. Absolutely.
Yeah.
Okay. So we've talked about the short-term effects then of influenza. So these are complications that we've talked about, such as bacterial pneumonia. We mentioned meningitis, encephalitis. Rarely there is, post-influenza encephalopathy. What about rhabdomyolysis, myositis? Is that something that you've seen in influenza patients?
Not often, to be honest. I don't think you could measure on average with every patient a massive CK response. But if you are constantly febrile, you're constantly shivering, you're constantly in rigors, you're going to have a myositis, you're going to have a rhabdomyolysis because of that. You might have a bit of breakdown because of lack of movement. So there's a potential, but it's not a commonly known thing. Myocarditis, again, I know we talked about this previously, but again, influenza can cause myocarditis, so affecting that form of muscle, but skeletal muscle, rarely so, usually because of that gross septic parameter that they have, or they can have. And remember, this can lead to a viral sepsis. We always think about bacterial causes of sepsis, but actually in Sepsis Month, as it is this month, we're trying to promote that all infective organisms, as the definition of sepsis is, an infective organism leading to end organ failure due to lack of perfusion because of the nature of the infection, can lead to that sepsis that we see. So anybody with sepsis should come in if they've got influenza.
Yeah, that's such a really, really important point to get across, is influenza can cause sepsis, or that systemic inflammatory response. So that's why it's really important, isn't it, to do those observations, that blood pressure, the heart rate, maybe do a VBG then, if they are hypotensive, tachycardic, you would have to do a lactate level, wouldn't you, to really identify what was going on. And what I do in these individuals who maybe I think has influenza, but they are pyrexial, tachycardic, hypotensive, I would go down the route of giving intravenous antibiotics before I was definite that it wasn't a bacterial infection, because I wouldn't want to delay antibiotics if I thought they were septic.
Yeah, and I think that's reasonable. You would do your blood cultures by then. You'd have a little bit more time to have a bit of a think. It's not unreasonable. I am a big fan about holding on to antibiotics and stewardship, but in these cases where you think something else is going on here, this is not a simple case of influenza with all of those classical things, then of course you would.
Yeah, and I think one thing you mentioned there, antibiotic stewardship, I think is definitely something that we need to talk about in a future podcast, is how we actually look after our antibiotics and don't just over-prescribe, because I know that's certainly something that we're probably all a little bit guilty of on occasions. We talked about short-term effects. What about long-term effects of influenza? I mean, I know that, if you do have influenza and you're frail and elderly, obviously the recovery period can be a lot longer.
Yeah, it can be, and if you're immunosuppressed as well, you can keep shedding viral particles for a considerable amount of time, or even virus itself. So that it can be a delayed response, and of course, with that brings about deconditioning, especially if you're in a hospital. It brings you to more potential hospital-acquired infections or associated problems. especially if you're somebody with a memory or a cognitive impairment. It's going to upset you the longer you're in that institutionalized place. But the direct effect, you can have a fatigue, a significant fatigue. You can have a chronic fatigue from all significant viral illnesses, and you can have a wearing of the whole body. I guess the direct system effects is that you can have a significant encephalitis, which will leave problems. And of course, if that myocarditis leads to perfusion problems, it can be quite significant also. And let's not forget the ultimate serious consequence, which is short-term or long-term, is death. Influenza is not something that is just a cold. This is not one of those diseases I'm going to turn around and say, it's just a cold, get over it, especially in our frailer populations. Influenza has definitely been known historically throughout many episodes to cause mass death in populations. We go back to the 1918 kind of Spanish flu, which was never really Spain. That was propaganda. It just was isolated in Spain. Everywhere had it. And people were dying left, right and centre. And again, in 2009 with H1N1, there was a significant population that were dying. And that was actually not the population that we're talking about with severe disease. Older people were okay-ish. Some people were dying because they were comorbid, but actually what we saw a real rise in our younger population doing very badly from H1N1.
And why do you think that was?
I don't know. I'm sure there's a lot of literature out there of postulating why that actually was. I don't know. In the pregnant population, we know how significant immunity changes it has to. You've got something else growing in you, which is unusual. Yeah, in the rest of the population, in the younger population, I don't know. We just saw them. And I remember lots of younger people in their early 20s not doing too well. And it was they usually died of pneumonia. They usually died of secondary bacterial infections.
Yeah, I remember cases because I think I was still a really junior doctor then. And I remember cases in the little district general hospital I was working at, of young people who were really sick, which surprised me. It was probably the first time in my career that I'd seen young people that sick from a viral infection, actually. So, I know you mentioned myocarditis, and obviously when you've got that pro-inflammation within the myocardium, there can also be an effect on the coronary arteries. And we do know that there is some research out there that shows that influenza can increase the risk of myocardial infarction as well, maybe a little bit later on down the line.
Yeah, sure. And I think that that's been stimulated and helped by all of the huge amount of research that was into COVID-19 diseases, with all of that kind of inflammation leading to thromboses and then embolization and all kinds of pro-thrombotic events secondary to inflammation. So yeah, I think we're going to learn more and more about that. It might even happen with the other differentials. So if we just think about the other differentials that we would consider at the front door, if you are lucky enough to have PCR testing and you've got a flu A, flu B negative, so flu A being the H1N1, the H3N2, the stuff that we're talking about that usually comes in a little bit earlier on in the English season, kind of November, December, January, February, March. Flu B following on, usually a little bit gentler, I guess, less severe disease process, but we have seen some significant flu Bs as well. If those are negative and your RSV is negative, of which it's not just a childhood bronchiolitis RSV, you can get significant disease from it as an adult. Then we can think about the other respiratory viruses, like your human metapneumovirus, your rhinovirus, that will be circulating at the same time. All have these diseases are all going to be transmitting exactly the same way. They're going to be droplets. If you're big coughs, you're going to be aerosolizing them. They're going to be passing, these can pass for meters and meters in small populations who are dominantly going to be inside in the UK because it's cold here in the winter, or it's wet, or it's miserable and dark. So you're going to be surrounded by quite a few more people probably in an enclosed space. So you've got those other things to think about. And if you've got the facilities in your trust, then you can ask for a respiratory viral panel as well. And that might help just prognosticate what's going on, and maybe even go back to the antibiotic stewardship aspect. If you've got that positive human metapneumovirus, you've got no real evidence of a secondary bacterial infection. After a couple of days of thinking, that's the time to stop the antibiotics. Don't finish off the course. Don't give 5, 7, 14 days. At that point, you've got a disease process. You know how it's working. That's when we can probably help with the antibiotic stewardship.
Okay, so that's really important, because I remember years ago we were told you always must finish the course. You don't want to develop antibiotic resistance, and that will happen if you don't finish the course. But that's basically completely swung round now. And obviously we're much more advocates of those shorter courses of antibiotics. And if we find an alternative disease process, stop them. They don't need to carry on for 10 days or 14 days. Absolutely.
And then the microbiologists and virologists in your trust will help you, guide you through that. But of course, you're seeing the patient usually, and it's very important to get all of that information together to say, actually, there's not a secondary thing going on here. I'm confident in that. And that's when you can stop.
Yeah, absolutely. Fantastic. Thank you so much. I think that was a really good recap on influenza. What are the 3 key learning points that you want our listeners to take away from today's podcast?
The 3 key learning points would be: think about the epidemiology, keep an eye on what's going on in your own country with regards to the numbers increasing. If there's no flu around, it's not flu. You probably haven't found the first 10 people with flu to come through your department at that point, but keep testing if you've got the facilities, because we know that it does follow a pattern, although skewed by COVID and mask wearing, etc. So that's point 1. Keep an eye on that. Linked into that, so that's a point 1A, and a point 1B would be that information will be given by UK HSA, what used to be known as Public Health England or Public Health Scotland or whoever. With that, it's our public health facility. They will give out good guidance with regards to how we deal with contacts, how we treat, and it might be old guidance, but they usually are some updates. So keep an eye on all of that information. 2, you've got some good tests out there, and if your molecular tests are negative, think about other things. Open up your mind. Don't be just fixed into this as flu, because we've been listening to this podcast. But think about flu and make sure that you do everything that we kind of have hinted on: the pregnancy tests, the HIV testing. Think about where people have been in contact, because your history is going to be giving all of that information. If you take a good history, it goes back to basic medicine. And then the third thing is that you've got specialists around the UK who will be able to help you out with the trickier aspects of this disease, or with the infectious disease differential. So use your virologists, use your microbiologists, use your infectious disease physicians. We're there to help support with this. But PPE is going to be the last thing that I'm going to mention. Just make sure that you've got your appropriate PPE on when you're seeing these people, because you guys need to look after yourselves. And the only way you're going to really look after yourselves is by getting vaccinated and making sure that you're looking after yourself holistically.
Yeah, absolutely. And I echo all of those points. I'd also like to, say that think about how influenza affects the elderly and the frail, and also that influenza doesn't just have short-term complications, but it can also have long-term complications. And it's really important that we do recognise that pro-inflammatory state of influenza that we've probably learned quite a lot about through COVID can then actually lead to increased risk of myocardial infarctions, myocarditis. I think we really need to be aware of that as well going forward. Absolutely. Thank you so much. And thank you to everybody for listening. If you want to tweet me, please feel free at Amie Burbridge. Massive thank you to Dr. Stephen Laird. Thank you for your invaluable time and your invaluable knowledge. If you want to learn more about influenza, please head to the EFIM Academy. We'll put the link in the podcast notes. And there are some modules on there which you can look at, which will go through influenza in a little bit more detail. Thanks for listening. Goodbye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.